Welcome to Nurses Showdown, Clinical Knowledge Battleground. Yay! super excited for this. And I'm your host, Felicia Igbinosa. And joining us for today's episode, we have two amazing nurses. Zed representing tele-PCU, and we have Chell representing the ICU. These are two different specialties that these two nurses will be competing for a cumulative point prize, which we'll be going over as we go over the rules. But first, before we get to that point, I'm going to have you guys introduce yourselves and let us know how many years you've been a nurse and what your nursing background is. So let's start with Chell.
Hi, everybody. My name is Chell Hernandez. I've been a nurse, registered nurse since April, but my background in healthcare starts in 2022 when I became a CNA. I've been working at the same hospital since that time, and I feel fortunate to grow within an environment that I know a lot of people. So I'm here, and I'm excited to be here. Thank you so much.
Ooh, thank you so much. Thank you, and welcome to Nurses Showdown. I really appreciate you joining us today. And now we're going to go over to Zed. Let us know who you are, how long you've been a nurse, and what your nursing background is.
Hello, everybody. My name is Zed. You can call me Nurse Lolly. So my nursing journey started off in 2016 when I started out as a CNA. 2016 to I would say for the most part, CNA for a year. Then I became an LVN for a couple of years, and then now I've been an RN for almost a year and a half now. So.
All right. Thank you both for joining us. I truly appreciate your presence here. So this show is meant to be entertaining, fun, bring your fun personality, bring your jokes, whatever, just to make it relaxing, entertaining. Okay? All right, now.
That's great.
This show, there is a prize to this. All right? There is a prize. There's money to be won. And this is the easiest way to make money. It's better than overtime. It's better than overtime. The easiest, the most fun way to make money. Now,
legally without responsibility, this is the easiest.
That's right. That's right. So the questions, because we don't want to make it too easy. We have to make it a little bit more challenging. We have to make it more fun, something to induce some thought provocation. So we are going to make sure we're asking you questions that are not limited to your nursing specialty. Okay. So we'll be having questions. We'll have questions from dialysis. We'll have questions from psych. We'll have questions from OB, from L&D. So yes.
Wow. I wouldn't mind a few CNA questions. I feel like me and Zed would be equal playing ground. I can chart every 15 minutes if they're sleeping. I can do that.
All right. Okay. So I hope you both have a writing, maybe a paper or pen or pencil with you, because you are going to be writing down your answers. All right.
Hopefully my brain is fresh enough.
Yeah. So bring back some of those OB and L&D and NICU.
Yeah, OB is a little bit challenging, but we'll figure it out.
Hey, yeah, okay, thank you.
All right.
I have my pen and paper right here.
Help me. All right, so here are the rules. whoever wins the most amount of money is, of course, the winner. And the other person goes home with a Jamesy Scrubs. Yeah. Exactly. So there's no loser here. You win either way. Now, the other person who goes on with the Jamesy Scrubs, whatever money you have left from your depletion will be added to the winner's money.
Oh, okay. See, I will lose on purpose if we get to split it.
Okay, so that makes it a little more, make it more competitive, right? Okay, so talking about Jamesy Scrubs, just want to give a shout out. They are sponsoring this show, and Jamesy Scrubs, these scrubs are super, super comfortable, super fashionable, and there's no way you wear Jamesy Scrubs and don't get compliments. I wear Jamesy Scrubs to work all the time, and I've seen nurses wearing Jamesy Scrubs at work, and they look fabulous. They are super comfortable. You can move all types of way in Jamesy Scrubs and still feel very nice and very confident. One thing I have to say though about Jamesy Scrubs is that they induce confidence in you. Confidence you never really thought you had. Once you have these scrubs on, they just like naturally comes out. So yes, thank you Jamesy Scrubs for sponsoring this show. All right, so are you both ready?
Where can I find Jamesy Scrubs? Do they have a website?
Yes, Jamesy Scrubs does have a website. You can get a pair or more. I will put the link somewhere in the chat box so that way you can reference it. www.jamesymart.com. Jamesy Mart, kind of like Walmart, but jamesymart.com. All right, are we ready? I get thumbs up. I need some energy in the room. Are we ready?
We're ready. Let's do this. Give me money or scrubs.
All right. So Zid, I'm gonna have you start off. So I need you to choose a number between 1 and 10.
3.
3. All right. So a patient becomes violent in the unit and is seen arming themselves with a broken chair leg. What is the nurse's immediate priority? A. Physically tackle the patient alone to take the weapon. B. Maintain a safe distance and attempt verbal de-escalation while following emergency response procedures. C. Film the incident on your phone for evidence. D. Ignore it because the patient is clearly agitated. You have 10 seconds to answer. You write your answer on a piece of paper.
Do I show my screen now?
Okay, 10 seconds is up. Show your answer. Okay, Chell?
Safety, number 1 priority, so B.
B, okay. Maintain a safe distance and attempt verbal de-escalation while following emergency procedures. Now, Z, tell us why you chose this answer.
Well, I mean, it's part of so we have A, B, C, D, E. So we got airway, breathing, circulation, disability, and also environment. So when you go all the way down to the environment, you want to make sure that everything is safe. So we start off with the safe distance, so you won't get hurt, and also the patient can. And then, a part of our job is communication. So you want to be able to talk your patient down. And then also we have our own mitigation plan, so where we, have our own responses to safety, as in calling security, things of that sort.
Okay. All right. Okay. How about you, Chow?
Well, I watch a lot of action movies, so I really want to physically tackle the patient alone to take the weapon. But I'm not, Liam Neeson with my daughter being taken. So it's always safe. We want to maintain safe distances at all times, and we always want to de-escalate because sometimes the patients, they just want to talk, they just want to be heard, they feel like they're ignored, and this is a way for them to gain the attention that they crave. And it's not so much about a matching reaction to them. You don't want to grab your own stick and be like, I got one too, let's go. But more of a, hey, let's chill out, let's calm down, let's talk. What is your main issue that is causing you this situation?
Okay, all right, very well. Now let's see what the answer is. B, you are both correct. Ooh, your money is untouched. So maintain a safe distance and attempt verbal de-escalation while following emergency procedures. And here is the reason. Safety of the patient and staff is paramount. Remove others from harm, call for help or security, and use appropriate emergency protocols. Tackling alone is dangerous, and filming, I'm pretty sure that's against your facility protocols, and that is not a priority.
You don't want to be TikTok famous for the wrong reason.
Yeah, exactly. No. Okay, so Chell, choose a number between 1 and 10, excluding 3.
I'm going to go with my favorite number, 8.
8. Okay. All right. So for question 8, a patient presenting with acute neurologic deficit has, let me move my screen away from here. Okay, there you go. Oh, perfect. Has a witnessed generalized tonic-clonic seizure in the ED before imaging. What is the most appropriate immediate action? A. Allow seizure to continue. Seizures are self-limited. B. Stabilize airway, breathing, terminate seizure with lorazepam, benzodiazepine, and protect the patient. C. Proceed with stroke evaluation. And D. Discharge once the seizure stops. What are we doing? 10 seconds. Write your answer. What are you going to do as a primary nurse of this patient? Three, two, one. Show your answers. Both at the same time. B. Okay. All right. Chow, why did you choose B? And let us know what your rationale is.
So, of course, I want to discharge my patients, but they're seizing. So I can't do that because when you're seizing, you're not in control of your own actions. So essentially, for the safety of the patient, I want to stabilize their airway, give lorazepam, Ativan, and protect the patient from any further injury. I know in nursing school we're taught to turn the patient to the left immediately and ask for someone to go get help if we're by ourselves.
Okay, very well. How about you, Z?
Honestly, I'm the same. Can't just allow the seizure to go on. It can cause significant more neurologically damage to the brain. You want to make sure that the airway is protected because that's number one priority. Patients can their tongues can tend to close their airways when they're having seizures. And then the lorazepam is really just to kind of terminate the seizure, as in like activities such as shaking and things of that sort, because it could be safety. So a patient can hit something, break something, things of that sort. And then C, they're not really showing any. It's a witness seizure. They're not showing any stroke deficits. And then you can't send the patient home after. You got to at least run some tests to figure out, how long.
But I really want to send them home.
I
really want to send them home.
Okay, all right. So you both chose B. Let's see what the answer is. Yes, it is B. Stabilize airway and breathing, terminate seizure with benzodiazepine, and protect the patient. And why is this your immediate action? Let me move this away again. Okay, I think it's better. Oh, okay. Acute seizures require immediate termination to protect airway and oxygenation. Benzodiazepines are first-line treatment. After stabilization, continuous stroke eval, neuroimaging and labs, as seizures may be a presentation of cortical stroke or mimic. So yeah, seizures could be a presentation of stroke. All right, so we want to treat the seizure first before evaluating for the stroke. Very good, very good. So Z, number between 1 and 10.
2.
2?
2.
Okay. Question 2. You have a post-CABG patient's chest tube output. A post-CABG patient's chest tube output is 250 mLs in 1 hour. Bright red drainage. What is the nurse's next step? You have 250 mLs of chest tube output in 1 hour of bright red drainage. What is your next step? A. Continue to monitor. B. Check the tubing for kinks. C. Notify the cardiac surgeon, the cardiologist, for immediately. C. Document and reassess in 30 minutes. 10 seconds. Three, two, one. Okay? Show your answers.
I wasn't as confident in this one, so my answer looks tiny. It's a little
C, D. Oh, okay. Okay. All right. Chao, let us know why you chose the letter D.
So in the ICU the other week, we had a chest tube with a patient who had a hemothorax, which is different from a CABG, I understand that.
Mm-hmm.
But the trauma surgeon said, do not call me unless it's 250 over in 2 hours back to back.
Okay.
And that's why I chose D, because I'm not waiting the full hour. I'm reassessing once I document that to see that if it's continuing, then I have to step in.
Okay. All right, good. How about you, Z? Oh, you're muted.
My bad. I went with C because I know there's a specific number that you have to notify within an hour. I think 250 is way too much of output within an hour. Technically, you would want to check for kinks first in the tubing, but you got to notify the physician. I believe it's 50 mLs within an hour, if I'm not mistaken. Per the book, but you know, ATI book.
Okay. All right, so let's see what the answer is. The answer is C. Okay. Yeah, Z. Notify the cardiologist immediately. 250 mLs is a lot within an hour. Output greater than 150 mLs per hour after a CABG suggests bleeding, requiring immediate surgical eval. All right. So, you're wiping up sweat off your forehead.
Yeah, that one was great.
Yeah. I'm always like, I always ask the doctor directly. I was like, when do you want me to call you? Because I will call you specifically.
All right, Chao. Choose a number between 1 and 10. We've gone over 3, 8, and 2.
Okay, I'm going to go with 6.
Number 6. Okay. So number 6. You have a 72-year-old woman with urinary tract infection, presents with fever, confusion, and a blood pressure of 82/48. Heart rate is 120 and lactate is 3.8 millimole per liter. IV access is established, but no fluids have been given yet. What is your immediate action? A. Give 30 ml per kg of crystalloid bolus and start sepsis bundle. B. Wait for blood cultures, then give antibiotics only. C. Give oral fluids. D. Discharge the patient home with oral antibiotics. You have 10 seconds. Three, two, one. Show your answers. A. Okay. Chow, why did you choose A?
It's very important that when patients are soft with their blood pressure, that is the first thing we treat when they're in code sepsis. Of course, we give them fluid bolus first, and then we move on to vasopressors next. But that would be the immediate action for this situation.
Okay. Very well. Z, why did you choose A? Uh-oh.
He says he agrees with me.
He agrees.
He froze.
You're frozen.
Yeah.
Oh, Lord. Okay. You're frozen, Z.
You know, he looks good frozen. Whenever I freeze, I have the ugliest face. So he's very fortunate.
It freezes you out at the worst moment, huh? All right, Z, go ahead and let us know why you chose A.
For the same reason, honestly, fluids is the number one priority in this situation. Also help with any hypotension, and also it can help with any with the heart rate as well when it comes to sepsis. And shout out to Dr. Shake for that.
Oh, okay. All right, Dr. Shake. All right, those are spontaneous teaching, right? Okay, so let's see what the answer is. Yes, A, you are both correct. Give 30 ml per kg crystalloid bolus and start sepsis bundle. And the reason for that is this patient meets sepsis criteria with hypotension and elevated lactate. Initial resuscitation includes prompt IV crystalloid bolus at 30 ml per kg while initiating the sepsis bundle. And the sepsis bundle includes the blood culture, antibiotics, and source control. You want to know where the source is, right? Early fluids and antibiotics reduces mortality in septic shock. All right, very well, very well. Z, a number between 1 and 10.
9.
9. Okay. Question 9. During a vaginal delivery, the fetal head retracts against the perineum, and it's called turtle sign when it happens that way. And this happened after the delivery of the baby's head. What is the nurse's first line of action? A. Apply fundal pressure to push the baby out. B. Perform McRoberts maneuver and apply suprapubic pressure. C. Begin immediate neonatal CPR. D. Wait for spontaneous resolution. 10 seconds.
Am I allowed to phone my OB friends?
Yes, you actually get one opportunity to call a friend if you must.
I'll call my mom. She was pregnant once.
All right. 3, 2, 1. Show your answers.
Okay, I'm so sorry, OB nurses, if I got this wrong.
B, okay. What's your answers? You're muted. Okay.
My internet was glitching, so I didn't even get time to.
Oh no.
Didn't even get time to what you were calling it.
Okay. So you need to write your answer?
Yeah.
Okay. You have 2 seconds. All right. B. Okay. All right. So why did you choose B, Chow?
So turtle sign to me is the head is down. It's in a way that might break the baby's shoulder. So the McRoberts maneuver turns the baby so that they're able to come out the vaginal canal easier.
Okay. All right. How about you, Z?
I really don't have a rationale for this one. I just know I'm not an OB nurse, but I've seen B somewhere before.
Okay, so no rationale. Okay. Let's see. Let's see if you guys got it right. B. Very good, very good.
My mom's gonna be so happy.
Yeah, she'll be so proud. Perform McRoberts maneuver and apply suprapubic pressure. And the reason for this is, so the McRobert maneuver, sharp flexion of maternal hips, combined with suprapubic pressure is the initial recommended approach to free the impacted anterior shoulder. Fundal pressure is contraindicated because it can worsen impaction. You want to make sure you call for help and prepare additional maneuvers if initial steps fail. All right, so we've done 3, 8, 2, 6, and 9. Was it Chow? Are you next?
Yes, I am.
Okay, choose a number between 1 and 10.
Let's go double digits. I'm gonna go 10.
10. Let's do it. So number 10. We have a 66-year-old with acute ischemic stroke. Is within 3 hours of onset, but had a significant GI bleed 3 days ago, requiring transfusion. What is your most appropriate immediate action? A. Recent GI bleed is an absolute contraindication. Do not give alteplase. B. Evaluate bleeding severity and consult the stroke team. C. Give alteplase. D. Start oral anticoagulant instead. You have 10 seconds. Three, 2, 1. Show your answers. B. B. Okay. So, Z, why did you choose B?
And this is my specialty.
Yep.
All right, so
He's cheating. He's cheating.
So I mean, A, it's technically correct. I mean, it's a contraindicated to give it. But the thing is what's our most appropriate immediate action, meaning that we have to do something. You wouldn't want to, so that means we would do B. We can't do C because we can't give it just due to the GI bleed. And also, same thing as in D, you're still given some type of medication that will cause them to bleed. So B is the accurate answer.
Okay, very well. Chow, you?
What the specialist said. That was the right thing. No way I'm guessing at all. I'm actually right next to Z, and I looked at his paper. I just thought consult, because in this situation, it seems complicated to have a patient with an ischemic stroke and having a GI. So it would be best to evaluate the bleeding severity and consult the stroke team before you make an action.
Okay, very well. Let's see if you're both correct. The answer is B. Very good, very good. Evaluate bleeding severity and consult the stroke team. All right, here's the reason. Recent major bleeding is a relative and absolute contraindication depending on severity and timing. Thrombolysis decisions should be individualized with stroke and hematology input balancing hemorrhagic risk against neurologic benefits. Guidelines list specific exclusion criteria, so consultation is absolutely important. All right. So Z, number between 1 and 10.
I'm gonna go 7. Lucky number 7.
All right, lucky number 7. Number 7. You have a 62-year-old patient on hemodialysis, complains of sudden chest pain and shortness of breath mid-treatment. The blood pump is stopped immediately. What is your next priority action? A. Check for kinks in the bloodline. B. Clamp the venous line and return blood back to patient. C. Administer nitro. D. Notify the provider immediately. You have 10 seconds. Three, 2, 1. Show your answer. B. B. Okay. So, Chow, why did you choose B?
So when we're doing dialysis, we're moving a lot of blood product into the machine. We have to return that to the patient before we do any type of treatment because they could be hemodynamically soft. So that's why I chose that one.
Okay. Z, why did you choose your answer?
Honestly, same rationale. The machine is already stopped, so there's no really point of really looking for any kinks. C, nitro can't really administer any medication in regards of this situation right now, and then notifying the provider would take X amount of time to treat the patient in this immediate situation. So B is the only smart answer.
Okay. All right, let's see if you're both correct. And yes, you are. Very good, very good. Clamp the venous line and return blood to the patient. And the reason for this is this presentation suggests an air embolism. The nurse should clamp the venous line, place the patient in left Trendelenburg, and return blood if possible to prevent air entry into circulation. Okay? Chest pain during dialysis could suggest air embolism. Very good. All right, Chell, what's your number?
Number 5, please.
Number 5. All right, number 5. We have a 68-year-old man presents with sudden left-sided weakness and aphasia 90 minutes after last known well. CT head shows no hemorrhage. Blood pressure on arrival is 195 over 118 millimeter mercury. What is the most appropriate immediate action? A. Give IV alteplase immediately despite blood pressure. B. Treat blood pressure with IV antihypertensive to achieve a blood pressure below or equal to 185 over 110. Then evaluate for alteplase. C. Send home with outpatient follow-up. D. Give aspirin and observe. 10 seconds. Three, 2, 1. Show your answer. Okay. Is that a B or D? A D? A D.
D.
Okay. All right, very good. Z, let us know why you chose D.
All right. So, number A, you can't give alteplase. I mean, they say to cite the blood pressure, but I believe the systolic is above 150. I mean, above 180, you can't give alteplase. Treating the blood pressure, usually when people come in with stroke symptoms, majority of them are for risk of hypertension. Because if we treat the blood pressure, then it decreases the blood flow to the brain.
Okay.
Can't send the patient home. The only smart thing to do is to give them a loading dose of aspirin within its first 24 hours.
Okay.
But I could be wrong.
Okay.
But I feel like my rationales.
Okay. All right. Okay. Chell, what's your rationale?
I think Z's right on this one, but for me, the blood pressure was high. I know we have permissive hypertension, and I agree with not dropping it too much, but my rationale was the idea that if we can get it below 185, that would be a lot better, and then evaluate whether we can give the alteplase.
Okay. All right. Very good. Good rationales. Now let's see if you're both correct. All right.
Is this a trick question? That's cheating.
All right. I think I need a drum roll for this one. Oh.
Just probably let him discharge and go.
Okay. Your answer is B. All right, Charles. All right. Treat blood pressure with IV antihypertensive to achieve blood pressure below or equal to 185 over 110. Then evaluate for alteplase. And here is the reason why we do that. IV alteplase eligibility requires a blood pressure below 185 over 110 millimeter mercury prior to treatment to reduce hemorrhagic risk. Rapid blood pressure lowering with approved IV agents such as labetalol or nicodipine is recommended for administering alteplase. Okay? So yes, we want to treat the blood pressure and bring it down. All right, very good, very good. That was a good one. Okay.
My unit don't see this, but I know my rationales can back it up.
Hey, you use your nursing judgment, and there's no right or wrong. You know, once your nursing judgment is at play, no right or wrong.
Don't worry, man. I let my guy bleed out with the chest tube after cabbage. So.
Okay, so Z, you're next.
I'm gonna go with number 2.
Oh, we already did number 2. 1, 2,
Number
3,
two?
4, 5, 6, 7,
Oh,
8.
we did. Number 1.
Number 1. Okay. Okay. So number 1. A patient returns from a percutaneous coronary intervention, also known as PCI, with a femoral sheath in place. The nurse notices oozing at the site and a drop in blood pressure from 128/76 to 92/60. What should the nurse do first? Let me move this out of the way. A. Reinforce dressing. B. Apply manual pressure above the site and notify the physician. C. Remove the sheet immediately. D. Increase IV fluids only. 10 seconds. Three, 2, 1. Show your answer. B. Okay. Very good, Chow. Why B?
Because when I was a nursing student, this happened, and I had to hold pressure for an hour and a half above her femoral artery. Basically, the drop in blood pressure indicates that there's a loss of pressure, and so we're thinking either septic or bleeding. They just had a PCI to the femoral vein, so automatically it's bleeding. So we want to apply pressure so we can maintain that pressure that we have, blood pressure, and then we want to call the provider and let them know what's happening.
Okay, very well. Z, what's your rationale?
Same rationale. When I was a new grad, I would say like maybe 3 months in, same situation happened where I had to put weights. I think we put on like 5. We started off with 2.5, and then we went to 5-pound weights, and then I actually had to manually hold it down. So that's really the only thing that makes sense in the situation.
Okay, all right, very good. Let's see if you're both correct. The answer is B. Good, very good, very good. Apply manual pressure above the site and notify the doctor. And the reason for this is the drop in blood pressure and bleeding indicates possible arterial bleed. Manual pressure above the insertion site is critical to control bleeding while alerting the provider. Removing the sheet could worsen the hemorrhage. All right, very good. So now we have 1, 2, 3, 4, 5, 6, 7, 8, 9. One more question, number 4. Okay. Let's go. Okay. So number 4, a patient who is ANO times 4 with acute mania insists they can make informed decisions and refuses hospitalization. But staff observe severe impairment in judgment and risky behavior. What is your next action as a primary nurse? A. Immediately discharge the patient because they say they are fine. B. Conduct a capacity assessment if lacking capacity and posing imminent risk. Follow involuntary admission procedures per law and policy. C. Ignore legal processes and forcibly detain the patient without documentation. D. Call their friend. You want to call their friend to pick them up. You have 10 seconds. Three, two, one. Show your answers. B. Okay. Why B? Z.
Let me. Oh, it's on mute. Can we go back to the answers or the?
Yes. Let's go back to the answer.
So starting off with A, we can't just discharge the patient because the patient says so. It says that they're fine. That'll be an unsafe discharge. C, you can't ignore any legal processes. That's technically kidnapping.
That's me in my 20s, ignoring legal processes.
And then you can't detain a patient against their own will if they are capable to make the proper decisions. And then D, I don't remember what D is, but I can't see it. But I don't.
D, here you go.
Yeah, you can't call their friend. Their friend is liable to say, yeah, it's fine, and just send them home. You got to do it the proper way. Perform the proper assessments. Then we can gauge to see if they're able to make decisions on their own. But the key word is imminent risk. That's what kind of threw it away for me.
Okay. All right. How about you, Chow?
I agree with Z. I think ultimately you want to see the capacity assessment. Nursing is all about assessing that high. So if they are posing an imminent risk, then it would be an involuntary admission, despite what the person says, because you see that impairment of judgment and risky behavior. So that should put your spidey sense on.
Okay. Even if they're ANO times 4?
Even if they're ANO times 4, because again, it's the risky behavior. Because if you discharge them, then you are legally held responsible for putting them in a situation where they could hurt themselves.
Okay, very good, very good. Let's see if this is correct. B, you are both correct. Conduct a capacity assessment. If lacking capacity and posing imminent risk, follow involuntary admission procedures per law and policy. And the reason for this is capacity must be assessed specifically if impaired and the patient is a danger to themselves or to others. Involuntary procedures may be lawful. Documentation and adherence to legal process are essential. Forcibly detaining the patient without due process is inappropriate. Yes, you're right. That is kidnapping. We don't kidnap people. Healthcare workers don't kidnap. We don't hold people against their will.
Even though they yell that into the hallways.
Right? Okay. All right. So we've gone over all 10 questions. But guess what? You both are tied. Yes. So we need a tiebreaker. And I have a question.
Oh, no.
We need a tiebreaker. I have the question, the perfect question to break this tie. Okay, let's see. Question 11. Okay.
Is it when to chart if you're PCU floor? I got that one.
When to chart? Okay, so here is the tiebreaker. A physician's order conflicts with the patient's advance directive. Do not resuscitate. How should the nurse proceed? A. Follow the physician's order regardless of the advance directive. B. Immediately refuse the order, document refusal, and notify the physician and appropriate leadership or risk management. C. Ask the patient to change the advance directive to match the order. And D, let me move this out of the way. D, ignore both the order and the directive until someone tells you what to do. You have 10 seconds. Three, two, one. Show your answers. B. See, I told you this would be easy. You both chose the same thing. All right. So why Z? Let us know, why did you choose B?
That's really the only safe thing. Honestly, you can't you can't go against a patient's their own wishes and their advance directives.
Okay.
So yeah.
Okay. I have a follow-up question with that, but let me hear from Z first. I mean, from Chell. Sorry, Chell.
It's okay. I would be lucky to look as beautiful as Z.
Oh, no.
So it's all about advocating. If you know what the patient's directive is, and it says DNR, and the the physician's orders conflict with that, you have to advocate for the patient. What B does is documenting the refusal allows you to know what the issue is, the thought process behind that issue is charted within the chart, notifying the physician to let them know, hey, they had an advanced directive DNR, so I can't do what you just said. And then letting the appropriate leadership and risk management know is important, because at that moment the physician went against the patient's wishes, and so that could be a legal issue in the future. Sadly, with C, you can't ask the patient. Sometimes in the ICU they're vented, so they're not as conscious as you want them to be, especially with some sedatives, some sedation, some pain meds coming in. So again, I'm not going to follow the physician's order. I'm going to listen to what the patient is, especially if I know what the advanced directive in this situation is.
Okay, very good. Now, what if the doctor goes in and the patient actually codes, and the doctor goes in the room and starts chest compressing against, even though he's aware of what the patient's wishes are, and he goes in the room and starts chest compressions, and you're there, you're the primary nurse, do you jump in and help him? No.
No, you would have to say stop, that patient is a DNR.
Okay. Very
You have a legal obligation to advocate for that patient.
Okay. All right, let's see if you're both correct. B. Very good, very good. Immediately refuse the order, document refusal, and notify the physician and appropriate leadership or risk management. And here is the reason why. Advance directives represent the patient's legal instructions. The nurse should follow them, and if a clinician's order conflicts, document the refusal, notify the physician, and involve leadership or legal/risk resources. Option A undermines the patient's autonomy. Option C is inappropriate in an acute setting, and D is just unsafe. All right, very good. Oh my gosh, how do we break this tie? Well, you both go home with your winnings. Very good.
We're gonna share the scrub. I'm cool taking the pants if you want the top.
You
or I can do the top and you get the pants. It's up to
I'll take the top.
You take the top, okay. All right, you both go with gentle scrubs, and I hope, I know it will actually look beautiful on you guys, and some of the scrubs are unisex, so yes, you can rock them to work as part of your winnings, and you both get to go home with your winnings. Thank you. Thanks for joining us. This was super fun. I really appreciate you guys taking the time to join me and do this show, Nurses Showdown, Clinical Knowledge Battleground. Was it fun? Did you guys enjoy yourselves?
Oh yeah.
Yeah?
That was great.
Oh,
We should
good.
definitely do a tiebreaker round.
Yes, we should.
Future.
That's a good idea.
I like the
ICU
everyone
nurse.
walks away with money idea, though. That's really cool.
All right, I'll let you guys go. Thank you so much and enjoy the rest of your night. And bye-bye. Bye.
Bye-bye.